Hi team, I have just received handover for our patient Mike, and there are a few things that were mentioned that I feel as though an assessment from the mental health clinical nurse consultant would be beneficial in addressing. He presented to the emergency department with a decline in his mental health as noticed by his flatmate and has disclosed thoughts of self-harm. As we all know, this should be appropriately addressed in a timely manner, as suicide is the second most leading cause of death among 15 to 29-year-olds currently in Australia. Rates of hospitalisation for males self-harming make up 36% of national self-harm cases. However, over the last 10 years, we have seen a consistent incline of death by suicide in males, which sees over 75% of the national suicide deaths be those of males, meaning males are significantly more likely to have fatal intention of self-harm as opposed to self-harming without suicidal intent. It is important that we understand suicide risk factors for Mike, as his age and sex can be used to target prevention and intervention methods in relation to his mental health. Some contributing risk factors include mood disorders such as depression being the most common, and anxiety, which we are aware he has a diagnosis of. Substance abuse and employment and life stresses are also risk factors for Mike. With some assistance from the mental health clinical nurse consultant and a thorough mental health assessment, I believe we'll be able to obtain a clearer care plan and build an appropriate multidisciplinary team around Mike to help in his mental health moving forward. What do you think?
Yeah, so I agree with Osha. I've also noticed in the handover that Mike said he was prescribed temazepam 20 milligram Nocte to help with his insomnia as he's been having trouble sleeping. Mike has said the medication isn't working for him. It kept him more awake at night. So as a result, he started taking Phenergan 10 milligram unprescribed to help him sleep. Research suggests that because Mike is taking undocumented medication, it can complicate Mike's treatment. And if we don't address this, it could potentially be dangerous, as Mike could suffer a wide range of adverse effects, and it could be ineffective at treating his insomnia. The mental health CNC will be able to address his insomnia and find a more suitable medication. Mike's also been prescribed fluoxetine, 20 milligram daily for his anxiety, which was first diagnosed at 19 years old. He's voiced his concern for this to be reviewed, as he feels like it isn't working for him and he still feels depressed. Research suggests we get the mental health CNC review this, as depression is strongly related to thoughts of self-harm, which he has been admitted to the emergency for, and must be addressed urgently to develop a treatment plan that is going to help Mike through his current situation. As Mike is having doubts about his medications, and is taking unprescribed medications on top, research shows as a result Mike's condition could fail to improve or even worsen. As he is having self-harming thoughts, there is the potential for Mike to misuse the medications. I think the mental health CNC team will be the best option for Mike to review his medications and find medication that is going to work better for him. They'll be able to assess his mental health concerns and develop a treatment plan that is best suited to his situation. Yep.
So yeah, I agree. Totally agree with Brianna and also Osha. But I am also concerned about his anxiety. And it was mentioned in handover that when Mike was admitted to emergency department, he was very anxious. He was having just issues with the nurses. He can communicate with some and not with others. He had very little eye contact with them. Like it was mentioned in the handover that like he wasn't sleeping well. He's got insomnia. He's on medication that he bought over the counter. He was diagnosed with anxiety when he was 19 years old. And since then, his doctor has put him on fluoxetine. But because he has issues with the doctors, he has trust issues. He hasn't been able to review his medication. And I think at this moment, he wants to look at his medication because his anxiety is, with his low mood, he had thoughts of self-harm. That's why the doctor has put him on fluoxetine. And so he wants to review that medication. So just with, with the medication, because fluoxetine was for self-harm and his low mood, he's having these thoughts of self-harm come back, and he doesn't want that. He doesn't want that to overcome his life again. He just wants to be normal. His long goal is to get off this medication, just so he can be normal. And I do agree that he should be referred to a mental health consultant nurse for treatment for his anxiety, so they can develop a better understanding about his situation. They can formulate a care plan and perform a more in-depth assessment of his mental problems that he has currently and in the past. They will also be able to develop strategies to assist with Mike's recovery. So in the meantime, while we think about referring, we can just help Mike with just having a good relationship with him, be empathetic, be understanding about his mental anxiety, and just help him to overcome his insomnia just by getting to rest a little bit and all that. And yeah, so what do you guys think?
Yeah, look, I totally agree with all of you. I think Mike needs to be referred to the mental health clinical nurse consultant. What I'm hearing from everyone is that we need a comprehensive mental health assessment in accordance with an agreed recovery care plan. We have a responsibility to provide recovery-oriented services to support Mike's intention to take greater control of his recovery journey. In Mike's case, it's important to move beyond the medical model, where one tends to view mental health challenges, such as those raised by Mike, as having physiological causes, and where the focus tends to be on the use of medication to manage these challenges. Furthermore, we need to move beyond the tendency for the medical model to cast recovery in terms of a cure rather than an ongoing journey. So it is important that we advocate for Mike's recovery within a contemporary mental nurse-driven recovery framework that's being implemented in Australian psychiatric and other wards, such as the Tidal model. I mean, this model puts the person's personal recovery experience and research at the centre of evidence-based recovery-oriented practice in Australia. It supports the principles of recovery by acknowledging that Mike is the expert in his life, empowering Mike to make his own choices about his treatment and instilling hope about the future. If we use the Tidal model as a guide, we need to refer Mike to the mental health clinical nurse consultant who is best able to elicit, understand and work with Mike's lived experiences. Mike is clearly unhappy with his GP and the medications he has prescribed, as you all mentioned previously, and this has led to disturbing behaviours by Mike, such as drug taking and self-harm thoughts. Mike is clearly in need of a recovery framework that will encourage him to tell the story of his life and how stressors have affected him, such as his new responsibilities at work and his move away from his family in Melbourne. Mike will then be able to identify what types of support he currently uses and what types of help he needs to move forward, such as reducing his dependencies on his medication. The great benefit of this approach is that it is strengths-based, where Mike will be encouraged to reflect on his life as one that he does not have to control, but rather navigate, and what resources he can draw on to aid in this navigation. It is imperative that Mike sees the mental health clinical nurse consultant to develop a recovery plan based on his lived experience, which can enable Mike to identify what he means by recovery, his goals for achieving wellness, what he can do to reach those goals, and timeframes and responsibilities for achieving the goals. I think we're all in agreement. Let's make the referral.